waiting for people to actually log in, including our main presenter. So we'll just give it a minute or two before we start officially. A very good afternoon to you all. I would like to warmly welcome you back to the fourth series of our webinars on COVID-19. I apologize for the slight delay at starting. This is, like I mentioned, the fourth series of webinars on disseminating information on COVID-19. And the last three seminars have seen us through the interim guidelines on COVID-19. And today it will be a presentation. Before we start, just a few practical information. This session is organized by the Ministry of Health together with University of Botswana and Rutgers University. Would ask all of you to mute your microphones during the presentation. Questions and answers session will be allowed after the talk. And there have been questions that have been sent in already that have been sent to the presenter. And we will, like last time, use the chat box and the rest taken after the presentation is over. Please be reminded that this session will be recorded and that it will be made available also after the session. To start today's session, I'm very honored to present or introduce our speaker, Professor Mosepele. He is the head of the department at the Internal Medicine Department at University of Botswana, and is also the acting deputy dean for research and graduate education. He is appointed as associate professor at the university and holds also appointments at the Harvard Chan Institute, Public Health Institute in Boston, and also at the Botswana Harvard Institute in Botswana. He's a specialist physician, an infectious disease consultant, and a clinical epidemiologist with research interest in HIV-associated cardiovascular diseases, autoimmune dysregulation, and also HIV treatment and care outcomes. As we all know, he's currently a member of the Presidential Task Force aimed at tackling COVID-19. So please, Professor Mosepele, the floor is yours.
all the attendees of today's call through some of the things we have done in Botswana to come up with a plan or a strategy to respond to COVID-19. As you all know, all of this work really initiated with the Ministry of Health as early as January. The president, I think around the 13th or 14th of March, decided that he will convene a task force that he will chair to lead all of government response to COVID-19. Right from the beginning, when we started, we had to respond to what was happening on the ground, whilst at the same time trying to come up with a plan. And in coming up with a plan, we were using a framework for emergency response plan. And that plan, which is used by several countries around the world to respond to emergencies, has got 5 stages. The first stage being preparedness, followed by prevention, followed by the response stage. The 4th stage in our plan is the recovery stage, and finally, the mitigation stage. This plan entails a lot of strategic actions at each level that will guide the response. And in all the strategic options that we come up with to inform our plan, we ask ourselves several questions. One of the first questions we ask about the disease that we are responding to include things such as transmissibility of the disease and the extent to which it can impact many people, the severity of the disease in terms of the extent to which we may end up with lots of case fatalities from the disease. We assess in any of those actions. We also think about the vulnerability of the population. Do we have many people with comorbid diseases in relation to this disease? And therefore, would that mandate some strategic action over the other? We also look at the healthcare system and say, in whatever actions we guide or advise on, what do we think is the capacity of the healthcare system to respond? Finally, after thinking through those characteristics of the disease and the environment, we apply ourselves to a principle within the team that we've coined a proportionate response. In that, what we do, we should always pause and say, is this likely to give us more positive results than cause harm in the community, or vice versa? Because it needs to be very, very clear that the things that we are proposing or doing will not cause more harm or are not too aggressive and might not give us, might help with the containment of disease, but cause undue harm in other parts of the community. Now, I'll sort of walk through some of these stages in a little more detail so that you can appreciate what has been happening before I conclude my talk with updates. Now, with regard to those stages that I referred to, I'll just highlight some of the things that we did or have done at each of the stages. In the very, very first stage of preparedness, we formed, working with the government, we formed this presidential task force. We had to debate its composition to reflect the different sectors of the community that will be affected by COVID, including private sector. We debated the structure of the task force and how it would relate to existing structures. In Botswana, we have the so-called district or national emergency response plan. And we looked at what we have in country for emergency response. And a lot of this actually rely on support at the district level. For those of you who are familiar with the Botswana governance sort of structure, one of the strongest things in the way this country runs is your district, where you have a district commissioner, your council secretary, your chiefs. And at each level in our society, we have people who provide leadership in the running of communities, to even communities that have 50 or 70 people. So we had to reflect on that structure in Botswana and say, how do we leverage existing structures that have been used in the past to respond to major drought, major disease outbreaks, especially amongst animals, but also even with HIV. Those of you who've been around could just remember what happened where at the very peak of the HIV epidemic and what structures we formed. One classic example that I can sort of show you or to demonstrate that we are using things that we've used before and worked well for us is, for instance, when HIV hit the country really bad in the past, it was taken out of the line ministry to the office of the president so that it can get the necessary attention. And hence why you can see some of the parallels with COVID, where it then got moved to the president and be guided by the head of state to help. It's still in the preparedness stages. We're debating the structures and what the functions of those structures were. We formed a command center. We ran 2 command centers centrally here in Gaborone. And for disease control or containment and minimization of risk, there's one command center where most, some members of the leadership sit. And then there's, in a different building, there's a second command center where you have more of the operations staff. And these command centers are run by people with the different expertise, ranging from logistics to communications to medicine and public health, security, social security. So all kinds of people we need to be able to form an effective response team. One of the things that we also worked on in the very early on in the preparation stages were to start thinking about a list of SOPs and guidelines that would need to be developed to respond to COVID-19. We had a long list of those. Some of them have been developed. Others are still in development. Still in the preparation stage, we started making projections of equipment and consumables that would be needed based on what we saw or read about COVID in other settings. So a lot of those projections were made very early, I think in the very middle bit of March and going into the end of March. Again, with this kind of outbreak, as you know that there was suggestion in other countries that limiting movement of people and the like would contribute to containment of disease. One of the things we also started doing very early on was to study and review the Botswana legislative framework to say what would be the provisions in Botswana that would allow us legally to respond effectively. And we studied the Botswana Public Health Act in very detail and sort of looked at that with the lawyers to see how that will dovetail or could be supported by the Constitution. So a lot of that work was done in March as we were getting formed. And so that was a lot of the preparation that was done. And then we moved on to our prevention. And this kind of ran parallel to our preparedness stage. So in the prevention stage, I would refer you to the government Facebook page, where you will see a lot of advisories. And a lot of these were issued in the Botswana context by the Director of Public Health Services, where you saw initially advisories, which are really kind of laws. For colleagues who are not familiar with the Public Health Act in Botswana, the director has the authority equivalent to that of a high court judge, and he can make and direct people to act in certain ways or not move or take away their possessions or instruct them to be subjected to a particular test. And you could see those are some of the things we did in the prevention stage, where we quarantined people as they entered the country. They were subjected to COVID-19 testing, and outside of the usual process of asking for consent, because it's a disease of public health importance. So a lot of those advisories in the Botswana context will be published in the form of the Gazette, and I think you saw a lot of those coming up, and that was done in the prevention stage. We then had a third stage in our plan called the response stage, and in the response stage we divided that into 4 levels, because we thought when the epidemic, when the outbreak occurs in Botswana, we did not know how many cases we would have, but we thought if we split up the response stage into 4 stages, that allows us to sort of, in a sort of reasonable and a proportionate manner, request for resources than assuming the worst case and then asking for all kinds of resources that one may not have. So in level 1, for instance, we said when there is no case detected, we will start responding by continuing with what we had done in the prevention stage. There are a lot of details that are with the Ministry of Health, which is the lead ministry in here, in which we even started talking about hospitals being advised to come up with their cough wards or cough beds, doing an audit of the oxygen availability, assessment of PPE across the country in each DHMT. And then in level 2, we said of the response, once we have 5 cases in the country, we would continue to now go beyond the healthcare system and look for additional beds outside of the healthcare system. For those of you who've traveled around Botswana, you know that we have teacher training colleges, we have schools, your regional education centers, we have all kinds of training. If you go to Mahalaka, for instance, you have the Botswana Prison Training College, which has lots of capacity for up to 400 people. So we started looking for government-owned property outside of the healthcare system that could then be leveraged to create extra beds in country to be able to admit people to those new beds should the need arise. In level 3 in our master plan, we had defined that as 25 cases detected. And in here, one of the running themes in our response or our entire plan is to always revisit this idea of to what extent does the Public Health Act allow us to act versus do we need some other provisions? So in level 3, for instance, one of the questions we ask is the Public Health Act sufficient? Engage with the lawyers, find out if you need more that needs to get done. And then in level 3, again, this is the one interesting thing about our planning to respond to a disease like this. We had initially said we would consider complete shutdown of movement in level 3, but because we had to react in real time, when we saw what was happening in South Africa, before we even got our 5 to 25 cases, we then did start debating the idea of a complete shutdown to reduce the risk of importation, and if any importation had occurred, to reduce the risk of local transmission. So we actually debated different forms of lockdown and settled in the form that you see now being used in the public. In level 4, we talked about maybe having a certain number of high care or ICU beds now being used, and the need at that stage to start talking about what additional measures we would put in place to ration resources for healthcare. And this will be familiar to most of you who've been following the COVID story globally, in that when countries reach a certain level, there has to be a serious conversation about who gets what. So these are some of the things we've thought about in detail, and then even talking about reactivating and reviewing the Ministry of Health, the safe burial policy, including individual or mass burials and the like. So, and then in the recovery phase, what we have done is we have imposed this sort of severe restriction of movement. That once that is removed or discontinued, we have a very detailed plan of how to slowly lift off and return life to normal. And that will be, progressive. It won't be, as on and off switch. And at the same time, we have what we call our mitigation activities. And a lot of these mitigation activities in stage 5, they don't just follow in that chronological order. There are things that actually some of them started in the preparation stage. You would have had different ministries present on things such as food rations for marginalized members of the community. You must have heard about loan forgiveness or suspension of loans for people who are in work but will not be able to get salaries, a wage subsidy plan by the Ministry of Finance. So we have all kinds of raft of mitigation strategies that we developed together with all the different line ministries, because we knew that this plan would require the input of all the line ministries, ranging from transport to trade. I mean, if you look at the Gazette, the last Gazette or law that was formed, you can see that the law touches on different things, including, for instance, sales of tobacco, sales of alcohol, use of public transport, and those have to be implemented by partners in this plan, who are the relevant ministries that have oversight over those other functions in government. So that is kind of a brief overview of the plan. But even though we had that plan, we were worried at one point that maybe there may be local transmission, or there may be cases in Botswana that we were not aware of. And so at one point, whilst we were clear on screening everyone who's symptomatic or suspected or high risk for COVID-19, we still went ahead and thought, even if we don't diagnose people, maybe we need to think about a strategy to screen high-risk communities. And this is what we talked about briefly on TV the other week. And we had that plan. It was sort of coming together nicely. We had teams formed and ready to hit the ground to screen for disease. But as you saw last weekend, we had 5 new cases being reported. And when those cases got reported, we thought, whilst we are still screening people for disease who present with symptoms and they fit the profile of people we consider to be high risk for COVID, we decided to then switch our plan completely and review the cases that had been diagnosed with COVID. And thought to ourselves, we are seeing the beginning of local transmission. And some of this local transmission would have potentially started in the lead up to the lockdown. And there may have been persons who had traveled outside of Gaborone who had been exposed to people who have now been diagnosed with COVID. And because of that, we thought, given the vulnerability of our healthcare system, it would be appropriate to then move our resources towards stronger testing, contact tracing, and isolation for the cases that have been confirmed and the contacts of those cases. So what you had over the weekend and going into this week was purely to respond to what we talked about in Mesino Klabe, Ramonswa, Mahalape, Bobonong, and Sivia. Earlier this week, we traveled to those 5 areas. And I just thought I would share with you the reception from members of the community. The reception has been actually very, very positive. One of the things that came out strongly from most of all the 5 communities we visited was that they were actually very concerned about the risk of disease in their community. A lot of community leaders talked about actually enforcing a stronger lockdown in their communities. There are communities where leaders have, on their own, executively decided not to issue this COVID-19 travel permits because they are worried that they promote movement of people and pose a risk to their communities. So from that sort of quick visit to all those communities, we got a sense that community actually agreed with a focus on strengthening diagnosis, contact tracing, and isolation. Now, in terms of where we are at, in terms of capacity for testing, which I think is very important, and I thought you would want to know about that, we have procured molecular tests, and earlier on we had procured some rapid diagnostic tests, and we accept the challenges that are associated with the rapid diagnostic tests. And as a result of that, we have decided to procure many, many more molecular tests. We're looking at a minimum, no less than 500,000 molecular tests. And this is purely for us to have capacity to test a good proportion of the community, because we are heading into the winter months and it's going to be very, very problematic to differentiate someone who's a high-risk COVID versus not. So testing capacity is one of the key things that we've been focusing on. In Botswana, with our current lab infrastructure, I think we are fortunate in that we've had RT PCR technology in some of our labs, so it wasn't such a steep learning curve. We have expertise in country to be able to do extraction for detection, and therefore we have brought on board, led by the National Health Lab, the Botswana-Harvard partnership. UB has come on board. Our partners in agriculture at the Botswana Vaccine Institute and the Botswana Vet Lab have also come on board, have been trained, and are ready to test. At minimum, at full capacity, we are potentially looking at ability to do about 3,000 tests in operating a 24-hour operation, which we think is a very good start. And when we get more machines through some partners who have confirmed that they will be delivering additional testing platforms, we will exceed the 3,000 tests per day to reach many more people to test. In terms of clinical care, and I've saw a lot of questions around recovery or clinic or the patients that we've had. By far, most of our patients are relatively young, except the one of our grandma who passed away in Ramoswa. They're fairly young. They mostly have been doing really well. Only one was very unwell at the beginning, required supplemental oxygen, but was able to come off that and remains off oxygen. So I think in terms of people doing reasonably well, we're very happy with that. The main thing that we are working on as a team between the COVID team and the ministry is to finalize our protocols for how to discharge some of our patients from care. We understand and are very much aware of the anxiety in the community around releasing people who have been confirmed to be COVID positive. The reason for doing this is there's anxiety. Second, this PCR test can give you positive results in the context of dead RNA material, not necessarily infectious material. And so we will need to converge and come up with a comprehensive guideline that incorporates the test results plus the clinical assessment or status of the patient. So those are some of the issues that we need to deal with. In terms of patient experience, some of our patients, I think, have appreciated what is done. Some of the things that have not gone so well has been the stigma, because I think colleagues have, it's been given a small community. People have been able to identify to some degree some of the persons with COVID and who they may have contracted it from. I think that has brought a lot of stigma against some of our patients. And if you recall, anyone who watched TV I think it was this past Sunday, we spoke out very strongly, urging our healthcare providers to try and get a reasonable balance between communicating detail to the community, whilst at the same time trying to protect the confidentiality and identity of people with COVID. It's been very sad that in talking to some of those patients, and this is not new, it started with our early suspected cases who were admitted to Seki Tumilo, where bullying even ensued online on people's Twitter accounts and Facebook accounts. So we've been pleading a lot with our colleagues in the healthcare sector to minimize sharing details about individual patients. So far, I don't know if I should proceed. I think I provided a lot of detailed. I don't know if I should answer questions that have been submitted, or haven't been, because I've been talking, I haven't been able to pay a lot of attention to the questions that popped up on the side panel. I'll ask for guidance from the host.
Thank you very much for your talk, Professor. Thank you very much for your talk, and also
Doc, I can quickly in 5 or so minutes run through some of the questions that have been asked that was shared by Mumakwa to the best I can. One of the questions is what
yes,
in terms of staff preparation for site care personnel training. My understanding is the public health team did a lot of training sessions prior to us arriving to assist in the response. I think some of those trainings continue beyond March 16. My view on this is we need to do more training. As the disease spread, we may need to use more people than folks who were initially trained. One question is, have we identified why patients, where they could have contacted COVID-19? I think this is referring to the 2 patients that were reported on yesterday. And these are part of one of the clusters that is already admitted at Sekiti Milamasiro. So we know, we have the details in terms of where they acquired the infection. It's an extra 2 of local transmitted disease. Can one develop resistance to corona? I don't think we know enough yet as to whether the antibodies that not everyone actually develops confers immunity. Why are other countries hit by COVID more than others? I think there are multiple factors there, but I think one of the main driving ones is the age demographics. In countries where they have many more older people with comorbidities, I think they've had worse disease. But that may not be the entire story. I think the response, the speed with which the response was done in those countries may also factor into why they were hit so badly. What is the plan to keep the COVID-19 cases under control post-lockdown? We are developing a surveillance program to identify sites, people, strategy for testing post the COVID-19 lockdown. I just want to pause here and say lockdown is really not a sustainable long-term option. It's an excellent option to contain and limit spread initially, whilst one is gearing up their systems in terms of testing, surveillance plan, so that once those are in place and well understood, then one can unlock to allow a return to normal life. What measures is being taken to contain spread? I think that we've talked about regional lockdowns. There's a question about whether we could do regional lockdown, and that is an option. If by the end of this lockdown, when it comes to an end, we have pockets of disease in certain parts of the country, we may do a regional lockdown restricted to areas where there's evidence of an outbreak and not a generalized lockdown. Are there any active plans to bring Botswana medics from other countries? I'm not sure about that plan. It might be frustrated by lack of or limited travel across the world or lockdown in the countries where they're in. The envisaged role of private sector in combating COVID-19. I think we have multiple private sector partners. For those, if there's any in the private sector here, the office that coordinates a lot of the support and input from the private sector is in the Office of the President, led by Remudimo, who's one of the permanent secretaries in the ministry. So please reach out to him. What is the management of COVID-19 patient? It's mostly supportive care. There's no known effective treatment, but we are working on plans to be part of some global networks to participate in clinical trials to treat people. Do we have enough PPE? Not entirely. Several reasons here. We did not have enough in stock from the beginning. We have been able to get some bought by government or donated. The main challenge here has been the shortage of PPE globally. And sometimes even when you can get it, you can't even get a courier plane to fly it to Botswana. But I think we should be getting a lot more in the next week. Chances of reinfection up in the air. I think there are people who are now thought to be retesting positive, but I'm not sure if there's true reinfection or just dead RNA material. One would have to combine the results of the test with the clinical picture. Why would it not be possible to publish names of personalities who test positive, especially senior government officials? I think even in the context of an epidemic, we respect individual rights of persons unless if they choose to disclose their results. I don't think it would be appropriate otherwise to do so. Any viral load test to monitor the virus, yes, the tests that are currently available, they all have different lower limits of detection. So I guess indirectly you can talk about a viral load, but in routine clinical care, we really look for whether the test is positive or negative, understanding its limits. But in study settings, there are people who are actually able to assess the viral load. But in this particular condition, we don't need to do a viral load. Are there any plans to build capacity in medical labs in East Regional Botswana to provide COVID testing? Yes, there are plans to do so, especially when additional platforms are available where DNA extraction and detection can be done outside Gaborone. Are there serology antibody testing? Yes, they are, but there's lots of problems with antibody testing in terms of their sensitivity. And then the other challenge is not everyone develops antibodies. How long does it take to get results back after taking a sample? It can be a matter of hours, but remember, after swabbing, there's the need to transport the sample, and then these tests are done, my lab colleagues can correct me, on a 90 or 96 well plate, and we would not want to use such a plate to just do one sample. So sometimes we may have to sort of get a few samples before we actually run a set. Is targeted testing alone enough to combat the virus? No, we will need many more other interventions to contain the virus. The test kits currently available in use for testing, are they specific for COVID-19? Yes, they are, the molecular tests that we procured. I'm aware that in the market, there are people who have multiplex PCR platforms that will detect COVID-19 and other respiratory pathogens. And we have an interest in procuring some of those for Botswana, so that this coming winter, we not only say you don't have COVID, but we can also say you actually have parainfluenza or respiratory syncytial virus. What are the chances of zero conversion after day 14 from negative tests? What are the chances of zero conversion after day 14? I think from the earlier papers, it looks like it's very rare for people to continue shedding infectious virus beyond day 8 or 10. Most of the virus that is detected after that is thought to be incompetent. And in the earlier studies out of Germany, when they did subject it to viral culture, it did not grow. Strains identified in Botswana, same as in China. This is I know I'm aware of a group that is has put together a proposal to do that in Botswana and tell us whether the strain is different to strains in circulation elsewhere. COVID-19 treatments, we talked about that. Medications taken concurrently for COVID. People are doing a lot of things. I think typically, because these patients present with what looks like a severe lung infection, we typically give them a third-generation cephalosporin and azithromycin, or augmentin and azithromycin, but that's just in case they have some other cause of pneumonia, but not necessarily that we are treating COVID-19. So that answers the next question about antibiotics, anticoagulants, and patients in ICU. I think our protocol, Dr. Halati will correct me here, and Professor Jarvis. I think we have probably done with our protocol on anticoagulant and providing DVT prophylaxis for all our admitted patients because of the preliminary evidence that suggests that one of the primary underlying pathology that contributes to significant hypoxia or ARDS is a microthrombosis in the lungs. So we are making sure that all our admitted patients get DVT prophylaxis to counter that other problem. How many recoveries that far? That's a question to be answered later. Is it possible to get a clinical summary of our 20 patients? I'm aware of a study protocol that is looking at a detailed summary, and I think that we should be able to share when that analysis is complete. Thank you, Doc. Hopefully I've done justice to all the questions that were submitted.
Thank you very much, Doc, for going through those questions. I hope our audio is better from this side, because we've been having problem with low volume at times, but there are a lot of questions that have come in the chat box. One of the questions has to do with availability of enough PPEs for all healthcare workers, and also encouraging more use of face masks in the community, if it is something that needs to be addressed more aggressively.
No, definitely PPE is not enough, and not only requiring for healthcare workers. There are many other frontline staff who are out in the community, screening people who need food packages. Police officers are out in the streets, monitoring movement, and these are some of the colleagues we will need to protect, both by using sanitizers, standing far from their clients and wearing masks. And I think this probably needs to be recommunicated again. About maybe 2 weeks ago, we issued a public advisory that is on government face page, where we actually recommended that members of the public can use homemade masks when they are in the public, especially in crowded settings. This was done, with the view that we have shortage already of our medical masks, and recommending that everyone uses the medical mask might actually compromise the safety of our healthcare providers, those who need it the most. But we have, I think about 2 weeks ago, issued an advisory to say members of the public, when they're out in crowded settings, which there shouldn't be many or none at all at the moment, that they can use homemade masks. Like I said, we are awaiting arrival of a large consignment of PPE.
Thank you very much, Doc. We are having some volume issues, but as long as you can hear the questions, that's fine. Yes, there was a question on contact tracing of the old lady who passed away, how adequately it was done.
I am reliably informed that it was adequately done by the DHMT. However, in this disease, if there's an opportunity to revisit it and look in more detail and identify gaps, I think we should, where we can do that, because I think a more sort of liberal approach to contact tracing, I think, would serve us much better than one where we assume we've done very well. So my view is, or what I have read, is it was done adequately. But like I said earlier, when I talked about areas that we are going to go into, this is to just go back and support some of our colleagues who may not have had adequate resources to do a far more extensive contact tracing. I think I'm seeing a few questions here on the panel that maybe I can talk to. What is the long-term plan for exiting lockdown? How to manage preventing a surge? I think a surveillance program would help us limit the possibility of a surge. Exiting the lockdown is going to be dependent on what we see sometime next week as we do more contact tracing. Is there a team within your coordination that educates capacity healthcare professionals in both public and private? The public health team in the ministry has been doing a lot of this. They are now getting additional support from Bumi and ACHAP. So I'm hoping that there will be more support for the DHMTs to help. Any SOPs available for isolation centers? Some of this exists, but I think our challenges sometimes have been understanding what they mean or how to implement the strategy. And one of the things we've prioritized, and that Dr. Haulate and Professor Jabis are helping us with, is actually completing and refining some of these SOPs so that we have a common and robust understanding of what we're supposed to do. Despite shortage of transport, any plans to deploy specific or certain vehicles to be used in Corona? One of the things we have suggested is between the Ministry of Health and Transport to look at a plan or possibility of authorizing certain taxis that would be, the drivers would be given the right protection. They will be taught about disinfecting their taxis so that we can provide some sort of additional transport for folks who need to come in for testing, especially if we have a lot of contacts that need to be driven into a central location for testing. So I think we need to look outside of Ministry of Health, including cars that are lying idle at the CTO and the like. Why did you settle for national lock instead of a regional lockdown? I mean, a regional lockdown, I think it's actually is what is happening. Both Zimbabwe, Botswana, Namibia, and South Africa under lockdown. So that is a regional lockdown. And there is conversations actually between the countries to appreciate what each one is doing. You know that I think South Africa has extended, and we are watching that space to say, what does this mean for us, and how much, to what extent do we want to align or misalign with them? And that's a question that we are debating. Can you assure health workers that we are fully prepared in terms of supplies? I think I've answered this, that there are some shortages, but they're being addressed with the caveat that globally there is shortage of some materials to produce this, and courier services have been limited, but now getting back into reasonable operations with China and unlocking. Do you think we'll be ready? I don't know. We'll be guided by the information. Do you think we'll be ready next week to end the lockdown? I don't know the answer to that question. I think we'll be guided by what we learn in the next few days. As you saw, in one day we registered 5 cases, and then 2 days later we registered 2 new cases. So depending on how things look, I think we will be guided by that plan. Any strategy or plan to test healthcare workers? I think there's been a lot of conversations about this. And what I've said is, when one tests a healthcare worker, they should just understand that that result says that healthcare worker has not been infected in the 2 to 14 days prior to the test. It does not say anything about the protection or safety of that healthcare worker from the day that test was done. So it's almost like digging a hole for yourself, where it's really difficult to come out of. Also, because you can't link, it's very hard to say, if Mosepele tested negative today and I test positive in 10 days, is that from home or my other contacts outside work, or is it going to be from my contacts at work? So it's very difficult to know what to make of the need to test a healthcare worker. My view is, if healthcare workers are given protection and take the necessary precautions, that's probably the most effective thing they can do, in that they will limit risk of acquiring infection. And if in the unfortunate case they're infected, they will limit the possibility of transmitting the infection to the other person. If there was effective treatment of prophylaxis, I think then there would be a very strong argument to say, let's test healthcare workers so that we can give them prophylaxis or give them some treatment because one is available. Any plans to decentralize testing, especially the Gene Expert platform? Yes, but again, good idea to do this. But remember, the technology is developed in a country that is badly hit now by COVID, and the chances are they are going to produce for that country first before they allow exportation of the testing material. And that has been a problem for a lot of a situation, or a lot of things we need to respond effectively, where when countries lock down, they introduce laws that limit importation. I'm aware, for instance, of PPE that was destined to arrive here, but could not, because the nation where it was originating had imposed limits of exportation of PPE so that is utilized for their citizens. Why did the patient from Severe have to be transported to Gaborone? Is in there in isolation? I think this is one of the anxieties from our healthcare workers. In some instances, they say a concern that maybe the isolation facility is not good enough, and hence they transfer to Sekitumile Masire, where maybe the team there has more experience in caring for these patients. But there are isolation facilities in almost everyday HMT. I think the big question is to go there, reassure colleagues that those facilities can be used safely. The isolation for patients who are COVID positive is a lot more straightforward to suspected cases. And we shouldn't, unless if we get hit really badly, we shouldn't struggle to isolate them at central locations in each HMT. On the test being performed, isn't there a possibility for a false negative? Yes, there is a possibility for a false negative. If the test is conducted early, too early before there is adequate viral replication, you can get a false negative. If the test is conducted way after the patient has been infected and cleared, then you will assume that the patient was never infected, when in fact they were positive but have just cleared the virus. If the technique for collecting the sample is poorly done, you may not get adequate sample material and end up with a false negative. If handling of the specimen from point of collection to the lab is not done properly, you may end up with a false negative result. I'm really curious as to the asymptomatic cases. Have we seen those? Yes, we have had patients who are COVID positive but remain symptom-free, which is one thing that really worries us and makes us think that might actually lead to far much more widespread community, far much more community transmission, because people may be infected and not know that they are infected. Do recovery after testing, did they come out negative? My view is the recovery should be based on a combination of factors, knowledge about the duration of disease, patient clinical symptoms, some tests if necessary, but I would urge that we don't focus on one thing to determine recovery. I think that is why the team led by Prof. Jarvis and Dr. Halati will finalize the protocol or definition of what recovery is in the Botswana setting. Should we use medical students and nursing students to help with screening after being taught? I think that's a brilliant idea. Other countries are doing that, and I think it would give them excellent on-the-job training. My voice is fading. Hopefully I'm not fading myself. Do you think we need to end lockdown? I've answered that. Do we anticipate high numbers of infections in the winter? I don't know. I'm worried about that, and we need to be prepared to look out for those. And hence why a robust testing strategy, contact tracing and isolation. Are you planning to acquire an antibody test? We will be getting almost, I think, 100,000 antibody tests. But like I said, there are issues with these tests that we will need to understand better, especially in the context of molecular tests, where we may have an opportunity to combine the two and understand how they perform in our setting. What is the latest on large-scale contact tracing exercise? This, I think, really kind of started yesterday with a few teams because we were augmenting our DHMT teams with the Archap and Bumi colleagues. I think yesterday was really more touching base, understanding what has been done. We had, I think, a good meeting yesterday afternoon where we talked about some gaps that we think we can close. And I think the teams should hit the ground starting tomorrow to do a little bit of more work. And again, our view here is a more liberal approach to this process of, likely identifying people as contacts and testing them, and not the latter position where you think unlikely and therefore not testing. Do you think there will be sequencing of the virus? Yes, there will be sequencing of the virus. There's a group that has a protocol on that. My voice is fading. I'll try and speak up. I went to the shop where people with masks were being forced to remove them as they were told. Council said they shouldn't allow masks. I'm not sure why. Like I said, go to the government Facebook page. I don't know if it was public advisory number 3 or 4 or 5, where we actually made it known to the community that in crowded settings they can use homemade masks. Should we expect the extension of the current lockdown? I don't know the answer to that. This is a really hot question. Could you use the antibody test to trace possible false negatives? It's a possibility, with the caveats that are pointed out. The performance characteristics of these tests are not so great, and some patients don't develop antibodies at all. Why are we not doing home isolation for mild cases? Excellent question. We should do that. Part of the reason to finalize these guidelines is so that we can do out of hospital admission. I don't know whether it will be home isolation for mild, given the number of cases. Probably we will do some sort of central out of hospital using, a regional education center or a hostel of some sort to admit those. Do we have pediatric patients? None thus far. We haven't had any children that I'm aware of who were positive. Regional lockdown in Southern Africa. Okay. Regional lockdown was, can we do regional lockdown in Botswana? Yes, we can. And we will if the need arises. If we see pockets, we may just close down on a certain region of the country and then allow the rest of the disease-free part of the country to keep going with their usual life. There has been comments about testing asymptomatic persons in quarantine around the country. We actually, and the question is, what is your view? We actually did this, if you remember, around the lockdown, we decided that everyone who went into quarantine would be tested. And the reason for this almost 5,000 tests done thus far reflects the extent of the testing among people who were in quarantine. Is it possible to get statistics of death certificates from December till now for the next 3 months? I'm not sure, but I think the deaths and deaths registry has those numbers and they can be approached for that. Any surveillance of people presenting with fever at any of the clinics to see if they already have community transmission? Yes, anyone who presents with some symptoms and is suspected should get tested. Like I said, the challenge would be in some places where they haven't done that, they may not have the swabs to do that. Do the kids come with quality controls? My understanding is yes, they do. The IDSA and ATS has given weak recommendation for HCQ. So the question is, the Infectious Disease Society of America and the American Thoracic Society has given weak recommendations for hydroxychloroquine. What is our recommendation? We have not recommended hydroxychloroquine because the data is, I would say at best, not the best, it's not the best data, period. And I think even these professional organizations have said we could use it in the context of clinical trials. And I think that is really where most people in the field would say in the context of a clinical trial. What are the future trends of COVID in the country? What is the expected peak? I think it's too early to say. Is there information on how many COVID-19 positive patients are known to be HIV positive? I do not have an answer to that question, but I can confirm that some of our patients have underlying HIV. What measures are taken to ensure that the test kits are not faulty before being used? I believe our labs run controls to make sure that the positives are actually positive and the negatives are negatives. And I think the lab did a great job even at the beginning by pairing our tests with South Africa. So which was, I think, great. Can you provide masks for law enforcement? Sorry? Oh, sorry. Yeah,
excuse
thank
me,
you.
Prof.
5
Yes,
p.m.
there are so many questions, and we appreciate that you are taking them the best as you can. We were thinking that we would allow the next 15 to 20 minutes maybe to allow for more interaction so that people who want to pose questions directly can have the opportunity to do so.
That's fine. I have to leave in about 10 minutes for my next meeting at
All right.
5 p.m. So, but I'm happy to hang around for another 5 to 7 minutes.
That's great. I would invite those who would like to pose more questions directly to Prof. Mosepele to go ahead.
Hello.
Hello, sir.
Yes, sir. Thank you so much for the detailed presentation and the detailed answering, Prof. My question is on the asymptomatic cases. I'm actually curious to find out, is there anything that links the asymptomatic cases that could explain why they're asymptomatic? So you can do like more of like a case profiling so that maybe you're able to identify populations that are more likely to be asymptomatic than others. Kind of like how a diabetic can have a silent MI.
Yeah, thanks, Doc. I think that's an excellent study question that we can look to profile. I mean, we know from other settings that it looks like the virus has a propensity in certain instances to attach and cause disease in the upper airway, whereas in certain instances it attaches in the lower airway and causes severe disease. So I think it will be very interesting to profile those folks in the region. But I just don't know if we have the numbers right yet in Botswana. But it'd be interesting to see if there will be reports coming out of South Africa to describe factors associated with mild versus severe disease in the region.
Good afternoon, Prof. I thank you very much for the wonderful presentation. I have two questions for you. The first question is the duration for the persons who have tested positive. For how long do we keep them in the facilities, and how does that affect on the cost of taking care of such persons, and the feasibility part of it if we were to have a lot of patients or persons testing positive? My next question is the one on recoveries. I'm just interested, just out of curiosity. I know you mentioned there are some few tests that you do to possibly look at the recovery, and can you just mention one or two tests that are used to look at the recovery, please, apart from the PCR test? Thank you, Prof.
Thanks, Doc. It is not sustainable and wise to think we are going to admit all our mild cases to the hospital. I think we should be looking at out of hospital admission, preferably the use of, like I said earlier, some government-owned facilities. I think it's not wise. I think we reacted this way in part because that's what we had prepared at the beginning of the outbreak in Botswana, and also because we needed to learn how to do this, maybe in one central location, get educated before we spread this out to other places. But we are going to have to admit mild cases outside of the hospital. I think there will be reluctance initially, and I would agree with that, to do home isolation for cases. I think it's very hard to police that plan. So a sort of out of hospital, sort of managed central place, I think would be far much more robust way of limiting transmission to others in the community. In terms of recovery, I'm not aware of, like I said, I don't want to talk about recovery on the basis of a test. I think we should take the whole clinical picture, whether someone, how long they've had the disease, what that clinical situation is at the time we want to consider them to have recovered. And if we are to use some tests, we need to apply ourselves and say, to what extent does this test mean recovery? And that's why I said earlier, I'm aware of the controversy or the differences in opinion around this topic. And Prof. Jarvis and Dr. Howlett will lead finalization of a guideline to address this concern.
Hello.
Thank you.
Thank you, Prof. I think
I'll
allow for one.
Okay, could I come in, please?
Max Kapanda, who has been raising his hand for quite a while. So since your time is limited, we will allow him to pose his question as the last question.
Thank you very much. Thank you very much, Prof. No, mine is a quick. I just want to hear, because I heard the Prof mentioning the homemade masks. Is there any specification, I mean, anything shared in terms of specifications in making those masks? Thank you.
I think it is homemade, any fabric that will help limit the spread of the droplets from a person who may be coughing and or maybe limiting acquisition of infection from someone who's close by. They're about 3 times less effective when you use some fabric from home compared to a medical mask. But I think the view, generally held view, is they confer some protection. I think one of the questions that was raised earlier about use of hydroxychloroquine, I just saw a post by Prof. Jarvis saying US they have issued guidance recommending against hydroxychloroquine and chloroquine in all settings outside clinical trials. So, we're still not using chloroquine except in clinical trials setting. Last one, so I can go, please.
One last question.
Okay, it's Professor Ray speaking here. Thank you very much. You've given us a huge amount of information, but I just want to push you on this thing about ending the lockdown. Because if we've got registered about 25 cases, and we know that this is a very infectious virus, then as soon as we open the border, because Botswana is not an island, as soon as we open the border, there's a risk of transmission. So how will you manage it? I understand surveillance, and I understand the issue about preparations for not being overwhelmed, but the risk of getting transmission has to be held against the whole issue of herd immunity. So it just seems obvious that there will be a lot more cases as soon as we open the border. And how are we prepared?
Prof. I mean, I knew coming onto this call that I was going to get pushed to give more specific about the lockdown and its future. And I can assure you, when a decision is made and a detailed explanation will be provided for whether it's being ended or extended, and I think all your concerns will be factored in. I think you are absolutely right about worrying about transmission from the region and or unmanaged local transmission in Botswana. And I think colleagues also in other sectors doing, economic modeling and the impact that they will have in the economy. That's another consideration to make. But I think, in my view, the future would look like something where once we have more information, we can come up with a balanced approach, especially in the context of a robust testing, contact tracing, and isolation plan. Because like I said at the beginning, the idea of a perpetual lockdown is probably not a viable option for so many other people in the economy. So I think a decision will be made at one point, and a detailed rationale for how that was arrived at will be provided. Thank you very much, Doctor.
Thank you. Thank you very much.
I don't know if
thank you very
much. I'm excused.
Very much, Prof. Mosepele. Source will not be covered, but they are noted and hopefully will be covered also during the future sessions this upcoming weeks. So let me take this opportunity to close. Thank especially Professor Mosepele for such a great overview and touching on a lot of different questions and clarifying them. So we will continue this webinar series next week, and you'll all also receive invitations on the next topic. So thank you, everyone, and see you next week.
Thank you.